Welcome, everyone. I'm Molly Thiessen, co-chair of the Academy of Medical Educators Grand Rounds Committee with Dr. Linda Montgomery. We're very excited to welcome an international speaker today. Dr. Victoria Brazel is a professor of emergency medicine and also the director of simulation at the Gold Coast Health Service in Australia and the Bond University Medical Program. Her interests focus on connecting education with patient care, using simulation, team development, and listening at conferences. She is also a distinguished faculty member at the Harvard Macy Institute and co-produced simulcasts and the Harvard Macy Institute podcast. And you may also recognize her from her Twitter at SocraticEM. So we are thrilled to host you today, Dr. Brazel, and can't wait to get started.
Wonderful. Thank you very much, Molly. And thank you for the invitation. Yes, of course, I don't feel international to me. I'm just at home in Australia, but it's very great opportunity to talk to some folks from the other side of the world because these are unfortunate times when we don't get to spend that time in person. Just before I start, I am going to be talking about the interplay, shall we say, between what we've experienced in 2020 and the pandemic and our medical education worlds. And I did want to just start by acknowledging those of you who are really in the thick of it right now over there. We are in a different place right now, but I did just want to say thank you for everything that you're doing in these really challenging times as clinicians, educators, and those that support them. So yeah, I wanted to take a little bit of a step back really and to get you to do some imagining for me. And I want you to imagine that we were back in November 2019 and you're sitting at your desk and this email drops in and it's a flyer for a seminar that's going to be done. And this flyer is titled Disease X, Pandemic Preparedness for Healthcare. And you sort of look into the detail and it's going to be presented by some fellow called Dr. Fauci. And it's going to talk about the impact of future pandemics on healthcare and education, things such as the difference between aerosol and droplet spread and what you're going to need to do to prepare. Now, the flyer says this is going to be on a platform called Zoom and you'll be able to put thoughts into a chat box. And at the bottom, of course, is a nice little friendly reminder about the mandatory online module you have to do on infection control. So I want you just to imagine if you were back in November 2019, what would you have done? Now, maybe if you're like Shanti and you're an infectious disease physician, you might have said, great. But if you're like me, you would have taken one look at that email and just pressed delete. And I think maybe like me, you would have been in a happy world of complacency. But let's imagine your interest was piqued a little bit and you thought, what do they mean by this disease X thing? And so you do a little bit of Googling and you discover that in fact, some people have been very aware about this future pandemic threat, and disease X was a name given by the World Health Organization back in November 2018 or no, November 2015 about some sort of future disease that they knew at some point was going to come and cause havoc across the globe, which of course many people would say is now. And it's fair to say that at least for me, and I suspect many of us, that happy complacency has been well and truly replaced with some panic. So I thought today we might think a little bit about what COVID has changed in terms of what we learn about in medicine, perhaps more specifically, how we learn about it in medicine, and take a little bit of a deep dive into that, albeit to think about this not as the end game, but as where we're at right now. I'm definitely not trying to pivot in unprecedented times or find silver linings, but I hope that there is indeed some food for thought. And the way that I thought we might think about this is in three ways. As I said, really just reflecting about how we do our learning, thinking a little bit about this connection between work and learning and whether these are separate together and maybe what the pandemic has helped us reflect on in that regard. But also maybe, especially as someone who's not normally engaged in as much public health as I should be as an emergency physician, maybe rethinking about what our role is as doctors, healthcare providers, for all of us to think about now being community educators and advocates for science and for reason. Now, I am very keen for you to put in your thoughts, and I've been reassured that the chat is where it's at in terms of some ideas that might feed some of our discussion after my initial comments. So I suppose by way of prompting some things to put into that chat, maybe just take a moment to reflect a little bit over your own 2020 as learners, as teachers, and for some people, I suppose, even consumers of healthcare. And just think about a little bit about your own balance between panic and complacency, and how has that played out for you? So I'm going to start with some of my own observations, and some of which will be similar to yours, some of which I think will be quite different. And I think the first thing to say is, in many ways, COVID changed what we learnt about. And certainly I can make comments from the point of view of emergency medicine. And it's fair to say it first of all changed what we thought we needed to know about. Those knowledge, the skills, the systems for effective patient care during the pandemic, how to diagnose, how to treat, how to use PPE, how to intubate COVID safe, how to resuscitate COVID safe. And for those of us in critical care, some kind of unfamiliar things, public health stuff about swabs and PCRs, isolation periods, R-naughts. These were language and lingo that didn't come across our desks quite so much. But in addition to changing what we needed to know about, it certainly also changed a little bit about how we learnt it. And it's fair to say that a lot of these really were panic mode strategies, at least in my shop. And there was heaps of simulation, and we did in our place, literally over 300 simulations in the space of 30 days. And as I said, a lot of that was really driven by the fear that we had, the understandable fear, plus what we thought were going to be dramatic differences in the way we did our work. But in addition, we saw instructional videos, posters, beginning and end of shift huddles. We had consensus guidelines coming out, it felt like multiple times during the day. Obviously, we had to go and watch Netflix if we were isolating at home, since there were movies like Contagion and Pandemic that we had to use also as great sources of information for our practice. Now, a lot of this was actually brilliant. And we were very fortunate, I think, to have support from local institutions, guidance from some of our professional bodies. And I do want to give a shout out to the people who were instrumental in developing a lot of those things. And I guess, again, speaking in emergency medicine in particular, we had some really well curated resources on social media with a backdrop of high quality providers of medical education online in our specialty. A lot of them really turned their attention to how could they produce good curation of evidence, updates on what people were finding, updates on research. So indeed, these were good things. But it's fair to say that in this how of learning during the pandemic, there was also a fair bit of challenging stuff. I mean, let's face it, there was also information overload, whether it was inboxes, WhatsApp groups, you name it. There were definitely a huge amount of drinking from a fire hose. The information-rich internet suddenly was really challenging to filter for quality. And there was obviously a lot of misinformation in there, or just poor information. My mate in Italy said, and suddenly that became the way that we were going to approach our pandemic. And, interestingly, so much variation in practice. I don't know why, but everybody seemed to have to make their own intubation guideline. And that seems, I think, to speak to some of our cultures in healthcare education as well. And again, for people who weren't as used to looking at it, graphs, statistics, curves, it felt like we were all becoming amateur epidemiologists. And so some of this was unfamiliar and difficult for us to discern if we weren't in that practice. And of course, a little bit unusually for much of our practice, suddenly there was also politics. Never have public health initiatives been so polarized and political. And I'm going to come back to that, because I guess as healthcare providers, that polarization was really challenging for us. I guess the other thing that's fair to say, and we were just talking about this before we started the presentation, the business as usual kind of got abandoned. Our usual education in many cases had to be cancelled, or at the very least socially distanced or virtual. Universities, simulation centres, medical schools, a lot of people just literally shut up shop. All education is cancelled without really taking a minute to think about how important that could be in terms of its role in the pandemic. But this was the frenzied panic where most of us found ourselves. And it's not the focus of this talk, but I think unusually, we also paused a little bit to reflect on the narrower line, shall we say, between our experience and that of our patients in this pandemic. And unlike many other things, this had a very personal impact, whether that was related to health or whether it was literally just due to loss of perceived opportunity, inability to travel, and many of the things that people found rewarding and fulfilling in their life and in their career. So these observations aren't unique. Everyone's had their own experience, but there are certainly some universal ones as well. But perhaps the more important question is, what now? And can we transform the panic that many of us have experienced into some better ways? And I guess just to sort of think back to that lecture of Dr. Fauci's that we might have been invited to, if it was held in person, it would have involved a couple of hundred people in an enclosed place. We would have been watching PowerPoint for an hour or more. It's pretty unlikely that we would have had any measure of whether we'd actually learned anything shorter than evaluations. And it's even less likely that they would have even asked the question about whether that lecture actually changed what we did in practice. These have been traditional stretches for healthcare education, but maybe there's a chance for us to rethink some of those things. Because if we are to really take those next steps, we've got to be thinking maybe COVID is having a real impact on education and training, to thinking about the what, why, and how we do it. So let's start with rethinking this, how we learn. And I guess the first question to ask is, can the lecture truly be dead? And, you know, the complacency with which we've wasted arguably thousands of hours as learners and as teachers sitting in PowerPoint slides is probably a little bit shameful. Now, the transition to Zoom has probably highlighted all the things that were wrong with PowerPoint lectures to begin with. So hopefully we did create a little bit of panic of thinking about how we get fabulous education for our learners, interactivity, meaningful, timely education. Because in fact, when we reflect on this, whether the lecture is dead, it's kind of funny that it has persisted, if we're honest, even this event here today, because we actually know what works, don't we? If we want to convey information, we just have to look at, like, TV, we have to look at the internet, advertising. These pieces have short, clear messages, illustrated with examples, embracing feelings, cognition, messages designed to have really personal impact. So, and they use media that supports that strategy. Little YouTubes, Vimeo, podcasts, cute tools like Doodly. We've seen them all when people are trying to sell us stuff. So what about when we're trying to sell ideas? What about when we're trying to sell messages that have to be really clear? Now, as a kind of meta level example, I thought this was actually quite a good one. So this 2019 study tells us in some detail about how posting a sign doesn't change hand hygiene behavior. Now, there's a lot of graphs in this study, lots of graphs actually, and maybe there's actually a better way though of conveying that information. And I'm reassured by the person who wrote this on Twitter that lamination also doesn't make a difference to that sign and its impact. But I guess it just makes us reflect, doesn't it? Because so often when we're thinking about our education, we think we have to put up the study with all its graphs, and the study isn't necessarily bad, but it's the story that we tell about it that is our educational impact. And so thinking how we can present ideas, thinking about how we transition that to a better way. So obviously our Zoom and other technologies offer a whole range of techniques about how to be interactive, just the discussion we were having earlier about whether we should be using Slido or Poll Everywhere. How do we actually get that interaction happening in our lectures? And in fact, in my experience, universities have talked about nothing much else for the last 12 months. But maybe as educators, we need to sort of fundamentally step back a little bit and think, is this really a problem with the technique or the technology? More likely, it's actually a problem with our embedded culture and our transmission stance as educators. We know that just because something is in our head and it comes out our mouth or it appears on a slide, it's not necessarily going to be transmitted into the head of our learners. It actually just doesn't work like that. Now, I think there's lots of better ways. And certainly if we think about conference, grand rounds, all sorts of other things, I think these are ripe for disruption. The tools and the technology will help us, but we actually have to change that stance a little bit. Now, I think there's lots of right ways to do that, but I was just actually going to share one that we've adapted when we changed our emergency medicine trainee. And we had actually done this before the pandemic, but as it turned out, it's been a really good format to take into the pandemic as well. So this is our active learning program, and it's the core learning activity for our registrars, or as you would say, residents in emergency medicine. Now, it's done in small groups of about 6. It can be easily remotely attended, and the principles in it are actually from test enhanced learning and also Paul Hydett's team-based learning. And what we do is we send out some pre-reading on a topic. Let's say it's about neurologic emergencies in the emergency department. And that pre-reading will just be 2 or 3, usually social media based resources. But as well as the pre-reading, each person is allocated what we call microdidactic question. And this is a very sharp focus question that they have to prepare a 3 to 5 minute answer for, no slides, just be able to answer question. So you can't just give them a topic like Bell's palsy. You actually say, what is the number needed to treat for steroids or for antivirals in Bell's palsy? So a very focused question. So then when they arrive at their class, they walk in and they get a test. And these are multiple choice questions. Some of them will pertain to the pre-reading. Some of them will just simply pertain to the topic of neurologic emergencies in the emergency department. They do those questions on their own. And then they actually spend a few minutes with one other person comparing answers and coming up with the best one between the two of them. So they do some peer learning and peer discussion of the topic. And then, of course, we go through them as a group. And then finally, they present their microdidactic talks. So it's a very learner-driven session. It's actually pretty hard work, certainly for the learners and for the teachers, but there's not a PowerPoint slide in sight, which makes me very happy. And most importantly, it actually is effective. And I always thought when we started this, I thought, gee, the trainees are going to hate it. It's going to work. It's going to be really effective, but it's so much work, they're not going to like it. But it's interesting, when you show learners how effective it can be, more often than not, they actually come on board with it, as they have done in this case. So as I think there's lots of right ways, but I think this invites us to really think, are there better ways than our transmission stance? So while we're thinking on the how of learning, I want to turn our attention a little bit to procedural skills teaching. And again, this is relevant for all of us in terms of some kind of clinical skills. In my specialty, obviously, some of these are procedural skills. Now, the inevitable move, I think, to remote, asynchronous, virtual ways of acquiring procedural skills has probably been hastened by the pandemic. And it's fair to say the enterprising yoga instructors and personal trainers who've run these online classes at home have definitely led the way about how to teach people some kind of physical skill. And so I think it's worth research signing up for one of these classes. So long before the pandemic, we knew that this kind of technology was there. This kind of virtual reality teaching, say intubation, increasingly is becoming available on consumer level platforms at consumer level price points, and allows us to slot into the learning cycle a huge chunk of potentially individual based practice before people come and do their first or subsequent procedures on our real patients, or even before they come and do a group based session using a mannequin or using simulation in other ways. But it's pretty interesting because this has raised some new questions about how we actually situate this procedural training within a learning context. So this doesn't come from my specialty. This is laparoscopic surgery simulation, but I do some work with our gynecology trainees in my simulation director hat. And this is a great thing. It's actually quite a cheap trainer, which is set up to learn these laparoscopic skills, whether it's threading a shoelace through a needle or whether it's actually stacking dice. These are accepted techniques if you're doing laparoscopic surgery. And this box trainer has some pretty simple instruments, and that is actually your phone, which becomes the camera, and then you can actually see things. And you can take these box trainers home and you think this is fantastic. Unfortunately, the trainees don't actually use them unless you embed this in some kind of a construct like test enhanced learning, or you actually set it up within the credentialing so that you don't get to be first operator in the surgery unless you've passed certain credentialing criteria on this device. So it isn't just a matter of providing the technology and they will come. So I think while we've got this move to create more asynchronous procedural skills training, we have to think about how actually that we do that. Likewise, this was a paper that I reviewed for one of the simulation journals, and it was a really nice description of how to build a 3D printed simulator for distal radius fracture reduction. So if you actually look at those pictures there, you can see this was nice. They obviously had some software that allowed them to print the broken bones, and then they put it together with little pieces of string and turned the whole thing into something that looked like a hand. Now, but perhaps one of the triumphs of this was not in the building of the simulator, but the fact that they actually then put this simulator in their equivalent of their minors area of their emergency department, allowing just-in-time practice just before people did a real distal radius fracture reduction. So I think this makes us rethink the idea of people leaving work to go and do courses or go and do procedural skills training, and maybe comes back and says, actually, we need to make more of these just-in-time opportunities, and there certainly is some technology that can help us do that. That's not a singular example. We've certainly seen many people do this and describe it in literature with things like lumbar puncture, doing just-in-time practice on a simulator just before they go and do a pediatric lumbar puncture, for example. So I guess the one other thing, just before I leave procedural skills, I think the pandemic has helped us consider the idea that procedural skills truly are a collective competence. So one of the things we discovered very early in our training in the pandemic was that the spotter or the buddy is arguably one of the most important people in the donning and doffing process. And I think what that should make us reflect is that, of course, procedural skills are rarely done as an actual singular thing. Generally, there are at least one other person involved, and probably we need to be training our intubations, many other things that we do in procedures in collaboration with other colleagues who are going to be there supporting, helping, and contributing to that procedural skill, because in fact, probably almost everything we do in healthcare is a collective competence, and it's not as simple as just sticking an emergency medicine resident in front of an airway trainer. So, we're having thought a little bit about the how we learn in emergency medicine. I guess I wanted to, and beyond, I guess I wanted to now rethink probably something a little bit more fundamental, because a lot of that was really thinking just about techniques. And many people are already quite advanced in some of these areas. And I think 2020 has just been a chance for us to rethink again. But I want to move my attention now to maybe something, as I said, really more fundamental. And that is, how do we connect learning and work? How do we reshape the connection between these two things to hopefully make both of them a little bit better? And I wanted to take a little bit of example of thinking about simulation, because as in my world of sim, I certainly know that around the world, a lot of simulation centers literally just shut their doors because of the social distancing, because of the difficulty in maintaining safety. And yet, of course, we also knew that paradoxically, this was probably one of our best tools to get people ready and to get institutions, teams, and systems ready by testing some of the protocols. because, clearly this was change on steroids, rapid, high stakes change. And as I said, we did more simulation in March at my hospital than we did in all of 2019. And, lots of other people did the same thing. But I guess I wanted to think about what this meant about the role of simulation and to get people to challenge the idea that this isn't just a way about how to learn CPR. In fact, what we were using simulation for, and I would say this is translational simulation, is to actually explore what is our current practice, where are going to be the tension points if we have to change some of those things, what are the weaknesses when it comes to infection control. Sim was also a way to test rapid cycle, iterative processes of let's see if this guideline is correct, let's see if this communication technique is correct, let's see if this is the best way to get the resources that we need, if this is the best equipment pack to have ready to go into our COVID rooms. And then finally, of course, more familiarly, we think about simulation to embed. Once we have decided what is our best practice, then we can roll out rapid things. So I guess this is an example of simulation, but I think it pertains to education as well. I think we've underutilized education for its exploration and testing role within healthcare and really focused more instead on trying to get people to norm to better behavior, when maybe it's got an opportunity to help us really understand our current behavior more. So, as I said, this gets probably to an even more fundamental concept about, just before I go on to that, I just want to mention this, because one of the examples that was really good in terms of using simulation to test was this one. This intubation box was widely supported and sold by manufacturers. And, if you look at it, you kind of think, well, this makes sense, doesn't it? You just put your patient in that box, it protects the person who's doing the intubation, and this is great. Until you actually test that in simulation. So these were some colleagues of mine who actually, through a variety of simulation strategies, actually tested this box at two different kinds of boxes to see whether it truly did protect people. As it turns out, unsurprisingly, it makes your intubation slower and less likely to succeed, which both are problematic in terms of COVID risk. But even more problematic, they found that people were having 7 or 8 PPE breaches per episode because with their arms in that box, they were tearing their gowns, they were getting other exposures that people didn't appreciate would happen. And so in fact, the intubation box makes your intubation more dangerous rather than less. And I guess these are the kind of things that we should be thinking about our educational modalities being the opportunities to explore. So no, let's turn our attention now to this fundamental idea about work and learning, and are they really connected in ways that we should have been? And we were, again, talking just before we started the presentation about, COVID really, because of this urgency and this panic, people were removed from the clinical area to do their education even more than they had been. And students were a pretty good example of that. A lot of them were pulled out of that area, and some of them were, not allowed to see patients anymore. And I guess maybe even more, it makes us sort of reflect on this protected time that we've had for our trainees, where we remove them from work and then we take them away to do education. Now, this is a very time-honoured approach, isn't it? Because we think, even in my sim sessions, I don't want the registrars having to be pulled back onto the floor to go and see patients when I want them actually to be able to do some dedicated education. And I know that certainly in the equivalent in most other countries, there's this protected time, usually multiple, some block of hours in a week, that is the education time for trainees. The trouble, I think, with that is that people start to see that as the only time for learning, because we're too busy in the clinical environment to do our teaching, despite many people's best efforts at bedside teaching and rounds. Somehow it's still seen that the real education potentially goes on in this structured learning time. Now, with medical knowledge apparently doubling every 73 days, that's clearly not going to be enough if we're not thinking about the work being a source of our learning, and probably the best source of our learning. And I think we saw some of this really happening, particularly for practicing professionals, when COVID prompted us to do some of these pre-shift huddles, debriefs, and when we really had to rapidly convey knowledge that people had learned in the course of their work to the next shift, the next week, the next group who are coming on to take over from us. And so I think we saw some really good examples, and this is one from Laura Rock in the New England Journal of Medicine Catalyst about how to do these kind of debriefs and huddles so that people had, I guess, the twofold effect of maybe relieving some of the anxiety we're feeling, but also the other effect of what have we actually learned today? What can we do better? And getting into these habits of reflective practice that actually are going to allow us to learn something from our work. Now, you know, the medical students have had their own journey as well, and these are some of ours at Bond. You know, we actually saw a huge amount of deferrals in first year classes because people were aware that medical school, or indeed many other healthcare and other pursuits, weren't going to be the same if people weren't allowed to go and do clinical attachments. And I think one of the problems is that we have thought about medical students, I suspect even more in my country than where you are, as sort of an optional add-on and not worth providing PPE to or risking infection. And some of this is about the separation of the healthcare reality with the university academic pursuits. And this disconnect is variable, but in my place, it's considerable. And so I just imagine if we had a system where the medical students were actually employed by the health service, supported in their training by a higher education institution, and actually did the useful work. And again, Shanta was telling me about how the students have really stepped up and the fourth year students are doing a great job. But why is this a surprise to us? And why hasn't this been part of what they do all the time? So if medical students came to work as part of their role and they thought about it as work, of course, they'd be worth the PPE. And doing various roles like being a cleaner, a scribe, a venipuncturist, an assistant in nursing, they're actually going to become great doctors in the 21st century. So I think this should actually rethink our models of where we situate our learners in the work continuum as much as in the learning continuum, because there's so much tacit knowledge in healthcare that can only be gained through really being embedded. And I think the pandemic has helped us to just rethink to ourselves, how do we actually do that in ways that are meaningful? And then the other bit that I really want to think about is assessment. And let's think about this in a few ways, because one of the things that the pandemic has made us think about is how do we know whether people are good enough at their work? And the sharp end of that has been in some of the retraining of workforce that needed to be done. So this is my friend Felipe Pisa. He works in Brazil, and he had to rapidly upskill a whole range of healthcare professionals to become critical care doctors and nurses in a short space of time. Now, often when we're confronted with a challenge like that, we go to process and we think about what we're going to teach. But instead, he went to the end point and said, how will I know if they're good enough? And really, how will I be able to assess that? And then the process should follow. And that's, of course, what we're supposed to do in medical education, but we often don't do it that way. And so I think in this way, and he very successfully did that, and I think made a big difference to how they were able to retool their workforce for that process. So I think it actually says, well, how do we protect the community? How do we make sure that people are good enough? But maybe some of our educational paradigms aren't necessarily the right ones. You know, we spend a lot of time working out who's got the distinctions, what's the bell curve look like, where's the cut scores. And we pull this from our educational paradigms, but really all the community want to know is who's not good enough. Maybe we need to be just thinking about where are those true negatives, as it were, and just focusing on finding those people and making our assessment processes a lot simpler. And maybe, again, the pandemic and the panic associated with that has certainly maybe put a spotlight on some of those issues. The last thing I want to talk about in assessment is open book exams, the rise of open book exams. Because during the pandemic, the inability to get people in a room and somehow isolate them from outside knowledge meant that many people did turn to open book exams. Now, it's much harder to write a question in an open book exam, but in fact, they generally test the much higher order capabilities of our learners. And so I think there's a lot being written now and a lot more thought to maybe we should be thinking more about that, because the reality is that in practice, it's not an open book exam. We've got access to all kinds of information, but we have to be able to have the skills to know where to look, how to filter it, and then how to apply it to a clinical problem, which is probably a much better thing to ask in an assessment than an MCQ about list the 10 causes of. So let's then, the last, just to rethink this last role. And I think one of the challenges, and this has probably been sharply highlighted for those of us who haven't spent as much time in public health, is to reconsider our role as community educators. Just show you that little thing there. And I'm going to come back to what I said before about politics, polarization, and information. And certainly for me personally, you know, I always thought public health was a good idea. I was so pleased there were people out there doing that work, but, you know, I was an emergency physician. It wasn't something that I did. I think we need to rethink this, because I think we need to know that in the 21st century, influence really is the commodity that we need to have. And to be able to communicate to our patients, to the community, these short, sharp messages. We've seen some great examples during the pandemic, but we've also seen some really poor examples during the pandemic of how we actually managed to convey good information that our community can use that will actually help. And I think if there's a good thing, it's that we would consider this well beyond anything to do with the messages related to the pandemic and start to think about how we embed better community health in what we do every day. And so I personally have probably been forced to think a little bit about, what does that mean for me as an emergency physician? What does it mean for me as a doctor? And how does it also mean that I convey this to our students and our learners, that I think we need to be front and center involved in community education for all the things that we know are important in healthcare. So I'm just going to leave my comments there for a bit and get some thoughts from people to prompt, disagree, decide something different, ask more. But I guess just to sort of summarize, as I said, really just thinking about the opportunities we've had to rethink that how of learning in healthcare, to rethink the connection between the learning and the work. And then, as I said, just to prompt some thoughts also about how we might be more involved in our community education.
Thank you so much, Dr. Brazel. My head is on fire with many thoughts about this. I'm going to, so people can put questions in the chat, which I'm happy to call out. Also, we have a nice group of 18 of us, so I think people could also unmute, and I think that would be great if people might contribute their thoughts and their questions.
They've all got shy now, Linda.
I know.
I maybe was going to jump in on the last part about the community. Sorry, Linda.
Oh, yes,
and think about the way we learn from our learners, about where they kind of put their feet and their hands and their hearts during this time, and how much we've learned about kind of what's important to them and how they can feel valuable, and what community engagement feels like from them in terms of the observations of what they've been up to. And that kind of could maybe direct us in other parts of our curriculum in terms of where we kind of invest our curriculum design and development around what they've told us through this pandemic is really important.
Yeah, I agree. And I think, you know, we thought we'd moved a little bit away from paternalism in medicine, but when you actually look at a lot of our messaging, it's still, look, trust us, we're the doctors, we know. And I think we've got to recognize that a lot of our community now have many sources of information. They're definitely motivated by a lot of feelings and, you know, affective elements as much as they are by any logic and analytical elements. And so we do have to turn, I think, to a lot of those modalities that we know people use for influence. We have to get better at our speaking points. You know, the politicians are much better at this than most of us are as doctors, and just have simple, clear messages Again, we've seen some great examples, don't get me wrong, we from public health groups, but it's really hard. And I think we have to see ourselves as part of that mission as well.
I'm fascinated. I had never considered the idea of a model of medical student education as employees. I'm a family doctor, that makes so much sense to me. Do you know if it's been experimented with anywhere?
Not really, but you know, we have this. One of the things is that, you know, Flexner did the right thing, didn't he? In 1910, he looked at all these little cottage medical schools and said, no, you have to get formal about your training. You have to move into universities and have 2 years of preclinical and then 2 years of clinical. And that served us well, maybe for 100 years, but it had some unintended consequences. And that is, it sort of said, okay, medicine is this academic pursuit out here. Whereas, let's face it, there's a lot about medicine that is a trade, it is an apprenticeship. And one of my friends who works in Tasmania said, well, we actually need to look at what in Australia we call the TAFE system, the technical and further education, or vocational training systems, apprenticeship models. Because apprenticeship is still a lot what it is. Now, there's nothing wrong with having a learning framework from an educational institution, but when you think about it, being part of the firm was probably how things were traditionally. So can we find actually a better balance? And maybe we've gone too far towards this higher education institution model, and we need to come back to this embedded workplace. I do know at UCSF, Catherine Lucy there was trialing in their Bridges curriculum something where they did have a longitudinal attachment. So half a day a week, the student was attached, let's say, to renal outpatients. And they actually went for that half a day a week for their entire course. And they started off, obviously, sweeping the floor and making the cups of tea and whatever, taking some blood pressures, doing some scribe work. And then by the time they were in 4th year, they were doing research and quality improvement projects and all sorts of things. But they had become meshed as part of the team. They got to know people, and they did all that tacit stuff that meant that the renal outpatient bit of it was fine, but that wasn't the focus. The content area wasn't the focus. It was the idea about being embedded within the system and within the team, and that could then accelerate the learning. I think the other example we've got in Australia is we have these longitudinal attachments where people will sometimes spend an entire year working in a small rural hospital, instead of going from obstetrics to pediatrics to medicine to mental health. Those students actually do better than the people who are attached to the professor of obstetrics in the big hospital. And I think we know why that is, because they become part of the glue, because they become part of the fabric of the healthcare institution, whatever its size, position, or whatever. They get responsibility. They have to make decisions. And so I think we can see that if we can manage to do this in a variety of ways, it would make a big difference. Now, obviously, there's a lot of political reality in terms of how you try and reorganize healthcare education and training. But I do think that an enterprising healthcare system, and to be honest, probably somewhere like Australia or Canada would be better, because we have these big statewide healthcare systems who could sustain having a thread of an education institution within it. So I think it's food for thought, and but I don't know that anywhere has done it successfully yet, simply because that impact of the Flexnerian approach has been dominant for 100 years.
Thank you. I just can imagine the pipeline. Who would go into the pipeline would be a diverse group of lion-hearted servants. You know, that would be great to see. It just it's very exciting to imagine it.
Yeah.
Thank you. I see you can probably see too. We've got some people putting things in the chat. Kent Boria says you spoke about reading in advance like a flipped classroom, then test and discuss with another. Have the students made the switch to actually read in advance or come in unprepared?
Yeah, great question. I think pre-reading has to have a purpose. So 2 comments in that. We also send out some pre-reading before our simulation sessions, and everybody reads that. If you feel like it's going to be applied, people do it. And because we, in our sim sessions, for instance, make no tricks about what it's going to be about. We don't say it's a sim, we're not going to tell you. We say we're going to do a simulation. It's going to be a beta blocker overdose. Here's some stuff to read. Then they definitely do read it because they feel like they're going to have to put it into practice. I think with any pre-reading, it has to be like all the messaging we said before. It has to be short, it has to be meaningful, it has to be in a modality that people will do. And I certainly know that when we put up things like blog posts and podcasts, high quality ones, that those are well absorbed because of the modality they are. I think if you put in a randomized control trial original paper, people are less likely to read that unless you're actually doing a journal club that's a methodologic review. But I think if you're actually talking about the content, like I talked about the neurologic emergencies, I would make sure that the pre-reading had short, sharp messages, was in a format that people would digest. Now, I'm not going to pretend my learners are perfect or that works perfectly every time, but I think that's probably, I have certainly made some mistakes in that regard in the past and have really turned my attention to thinking, how can I make this as simple, short, and applied as possible? If you're coming to do an MCQ as soon as you arrive, that is also a bit of motivation as well, because people want to do well and they know that they're going to get tested, albeit in a low stakes way, when they arrive.
Thank you. Are there questions? Comments?
I could perhaps ask people, I'm not sure how many online are teaching procedural skills, but I'm interested in how people have adapted to that, and whether you see this virtual reality being an opportunity or a threat or all too hard still.
I'll pop in. We teach procedural skills. It is a big challenge, obviously. There's just some muscle memory things that you teach with your hands. We've tried to do it, we do like office-based procedures like endometrial biopsies or things that we use in obstetrics like FSCs, things like that. And we've had small groups with honest like models that we'll create out of fruits, vegetables, and animal parts, and just get a group of 5 learners together. So much smaller training opportunities with sort of a pre-video. So we've have had to make much smaller learning opportunities, and it has been a struggle, and I don't know how it will work out, but it seems to be sort of our new training opportunities, trying to figure this out with our learners.
Yeah, and actually it's interesting, obstetrics and gynecology, I know from Simulation World, have done a great job of low-cost part-task trainers that can replicate the challenges of the procedural skills. And I think that certainly helps if you have got good modalities that then you can embed in the learning paradigm. And I think the other thing is people are getting better at assessment using those tools. So one I didn't mention for those gynecology trainees is they also have this very fancy virtual reality trainer. And the best thing about that is that it actually can measure things like how far do your hands move and how many mistakes do you make and what's your path length when you try and get to a certain procedure. And so, in fact, the machines can give much better feedback than the specialists or the attendings can for the trainees. So I think we're also going to see that asynchronous training will be good because, in fact, there is better feedback and more objective feedback sometimes that the machines can give. It won't be instead of the experts, but it'll probably be a really important element that means when people are then face to face, they'll be able to make much more of that opportunity, I hope.
I think the hardest part, I'm a ENT doc, and I think the hardest part of teaching procedural skills in the absence of patients, like in a virtual setting, is the haptic feedback is just different. So all of these low fidelity models are just difficult. Like we have an epistaxis trainer that we use, and it just doesn't feel the same when you put the pack in the trainer than does when the patient, and they're also, the trainer's not yelling at you like the patient is in pain. And so I think that's the hardest part. We haven't used virtual reality, but that would be really interesting to be able to use. I wonder if you could even have the virtual reality simulator give auditory feedback too.
Yeah, so I've seen some really interesting things in that regard, Christina, but you're dead right. I mean, I think we've got to see what things are good for. And some of the low level virtual reality, sort of just using the Oculus Quests and the little gamers devices, it's actually good if you just want to get into the sequence. So if you take your example here, I've got my Quimpet out here and I've sort of laid out my silver nitrate sticks and I've got my little pledgets that I'm going to stick up their nose and I've got my little stuff and I'm going to put on this light first. So it can sometimes get you into that sequence of things, but you're right, it won't give you the same sort of feel of it. I do think some of the virtual reality is going to get there when it comes to the feel, and having seen some of those laparoscopic skills trainer, I think the people start to feel like, oh yeah, that just feels like the back of the peritoneum when I poke it, and that feels like a uterus when I poke it. So, you know, these, they tell me that that actually is pretty good. So I think we will start to get there, but I think it's a matter of sort of deciding what gap does it fill and what gap does it not fill. I do think the combined hybrid training of patient interaction with procedural skill, you know, people have done that obviously with stuff like suturing pads and stuff like that, that they put on real people. And I don't think it would be too much of a stretch to have either an avatar or someone else yelling, as you say, or at least asking questions to kind of have to get people to be communicating at the same time that they're thinking about their procedural skill as well. So I guess we watch this space with interest, but you're right, there at the moment, there's certainly no one size fits all or one solution to what is, to be honest, a training journey.
Thank you. Any other questions for Dr. Brazel?
Yeah, I was curious about the simulation that built in the hand motion analysis into it. Was it built into the trainer, or did they do the hand motion analysis separately and then analyze the performance?
Yeah, so two ways that I've seen that happen. One is sort of just traditional psychomotor analysis like they do for basketballers or sprinters or whatever, where you've got the green screen, they have a video and they put the little dots on your joints. And again, I'll speak from my area, but airway management has been an interesting one. So there's a difference between your hand being at this angle or that angle, moving that way, and then how far does it move when you're doing your laryngoscopy. And so then they can just sort of track that through motion analysis. So that is actually a physical tracking process. And I've only really seen that done in research labs as people are trying to establish measures of procedural proficiency. But where we are going in these laparoscopic skills trainer is this is all done with software. So if you have an instrument and you're hanging onto the guides outside, there's no actual instrument inside the box. It just creates a virtual representation of that. What the box measures is how far is your hand moving through the impact that it has where it meets the box. And so this is actually all software based, and obviously they've got clever algorithms in there that can actually do the maths, and it gives you things like what they call path length, which is how far does your hand move, smoothness, which does it move in multiple jerky motions, or does it move smoothly from one task or one position to another. And then obviously in some cases there's metrics like, have you hit the ureter, have you managed to cut an artery, and is there blood loss? And then they factor in things like, if you do cut something, how fast do you lose the blood, and then how long does it take you to put the clip on that would stop that. So there is both a physical research group groups that look at that, but I think the big move is to the virtual reality ones where the software really does some of those algorithms. And I think what that helps us do is understand what expert looks like, and then that helps us give the feedback to people who are on outliers of which of these things they're doing well and which they're not doing well. But it's a fascinating area of research. It's not my area of research, but I read a lot of it as in my role as a simulation journal editor.
Great. Thanks for that. Appreciate it.
Awesome. Well, I think we are wrapping up to the end of the hour already. I know folks probably have afternoon clinic sessions. I want to say again, thank you to Victoria, Dr. Brazel, for joining us from far away and really not so far. Your conversation was really stimulating, and I think we'll have a lot of follow-up discussions about how we can apply what you've taught us today as we're looking at our curriculum going forward. Everybody on the call, I want to remind you that there's a link that Erin put into the chat. Thank you so much, Erin and Jody, for hosting us today. There's a link for you to give us feedback, including to give us ideas about other topics that you might be interested in hearing. And again, I think, Victoria, you stimulated some ideas in my head about other things that we should be thinking about. We definitely enjoyed having you and would love to have you back in person sometime.
My pleasure. Thank you so much, and keep doing your good work and stay safe.
All right.